Hello everyone. So we have a 51-year-old man. He come to you with difficulty in swallowing solid but not liquids. His medical history is significant for gastroesophageal reflux disease, GERD. For last 12 years, he underwent upper GI endoscopy and was diagnosed with Barrett's esophagus 6 months ago. The heartburn resolved 3 months after the diagnosis without any treatment. It's a very important point to be noted. Vitals are normal, but his body mass index is 38. That means he's very, very obese. Now, Barium Swallow shows an area of symmetrical, circumferential. Again, point to be noted, it is symmetrical, circumferential narrowing affecting the distal esophagus. Now, which of the following best explain this finding? The answer to this question is esophageal stricture. Well, patient presentation is chronic GERD. His medical history is for 12 years. And new dysphagia. Now, he had difficulty in swallowing solid but not liquid. Remember, this is a new onset dysphagia. And this symmetrical lower esophageal narrowing. This is a very important point, symmetrical narrowing. Why it is so important, I'm going to discuss in the coming slides. This suggests esophageal stricture. Okay, symmetrical narrowing suggests esophageal stricture. Well, you can see the esophageal stricture is there. And this can be treated by a balloon dilator or maybe dilator, and stricture get opened up. That means we can very well treat by dilator. Okay, anyway. Now, GERD predisposes to Barrett esophagus and it can lead to esophageal stricture. Our case is a known case of GERD for 12 years, and now Barrett esophagus was diagnosed in the previous endoscopy, and now the patient has esophageal stricture. Well, in Barrett esophagus, there is intestinal metaplasia of the lower esophagus. Now the question is, I have a question for you. Stop the video, write down the answer. Why we call as intestinal metaplasia? Write down the answer in your copy. Well, so why it is known as intestinal metaplasia? For that, you got to know the basic concept. Okay, this is the lower end of esophagus, and this is the stomach, and this is the lower esophageal sphincter. Normally it remains closed, is a physiological sphincter, it's not an anatomical sphincter. And the lining of the lower end of esophagus is a squamous epithelium. So due to lower esophageal sphincter, this remains closed, so acid cannot go up. But if it is not patent, the acid will go up in the lower end of esophagus. So as a defense, the body tried to make columnar epithelium. This squamous epithelium is replaced by columnar epithelium. It's just a defense against the acid. And that's why, and we are well aware that in the intestine, it's a type of columnar cells are there. So that's why the term what we use is intestinal metaplasia. In fact, when we talk about metaplasia, normal lining is squamous, but now it has been replaced by the columnar lining. So that is again a term we use, metaplasia. Metaplasia means a tissue which appears at a particular place, which is not a original tissue. The columnar epithelium is not a lining of the esophagus, but it is appearing, especially in the lower end of esophagus. That's why we use as word metaplasia. Since the cell resemble like intestinal, we use as intestinal metaplasia. So now, when we talk about Barrett esophagus and esophageal stricture, both are consequence of body reparative response to chronic gastric acid exposure I explained to you in the previous slide. Both can occur simultaneously, like in this case, patient is having both the things are at the same time. Benign stricture affect about 5 to 15% of the patient with GERD. Other causes of esophageal stricture include radiation, systemic sclerosis, and caustic ingestion. They are the other, but they are not common causes. Stricture typically causes slowly progressive dysphagia to solid but not to liquid, as in this patient also. Anorexia is not a feature. It's a very, very important point. So that's why typically no weight loss occurs. This is a golden line to remember. Don't forget this line. So as they progress, they can actually block the reflux, leading to improvement of heartburn symptom. Like in this case also, his heartburn symptom resolved after 3 months. Why? Stricture occurs now. Stricture has occurred. Acid will not go up. The heartburn problem get resolved. So stricture appears as a symmetrical, circumferential narrowing. What we saw in the question also, it was written that it is a symmetrical, circumferential narrowing is there. Well, in any case of stricture of setting of Barrett esophagus, biopsy is necessary to rule out adenocarcinoma. It is accompanied by a endoscopy, and it may be diagnostic or therapeutic. Well, I have shown you the picture already that we can dilate the stricture by the dilators. But dilatation is done only if there is no malignancy on biopsy. Let's look into other option. Ecclesia is an esophageal motility disorder. It presents with dysphagia for both solid and liquid. But in our question, it is only for liquid, only for solid, not for liquid. So this is ruled out. Regurgitation of undigested food is a finding that we get in Ecclesia, but is not seen in our case. Barium swallow in Ecclesia will show aperistalsis. Why? It's a motility disorder. Poor emptying of barium, dilatation of proximal esophagus caused by retention of food, and that classically gives a bird beak appearance at the esophageal, gastroesophageal junction. This you can see. Classical finding, can't afford to forget this picture of finding of Ecclesia, narrowing in the lower esophageal sphincter. Let's look into other option. Option B, esophageal adenocarcinoma is occurs in patients who have GERD for more than 20 years. But in our case, it's 12 years. Early symptoms of esophageal cancer are subtle and include retrocerebral discomfort, mild dysphagia to solid food, but in our case, only liquid is there, and or burning sensation may or may not be there. Barium swallow generally shows asymmetrical narrowing of the esophageal lumen, but in our case we are getting symmetrical circumferential narrowing that rules out adenocarcinoma. So now let me show you the Barrett esophagus and adenocarcinoma. Barium swallow, northern mucosa of the Barrett esophagus, and raised filling defect representing adenocarcinoma. You're getting filling defect is there. And this is the so-called nodular mucosa for the Barrett esophagus. Let's look into other option. Option D, Hightest hernia is a protrusion of the stomach above the diaphragm. That means stomach is going up in the thorax. It may have GERD and lot of also risk factor for Barrett esophagus, esophageal stricture, adenocarcinoma. But barium swallow will show gastric fold protruding above the diaphragm. It's a classical finding of what we get in Hightest hernia. Now you can see this is a sphincter. Hightest, this is a diaphragm. The stomach has gone up above the diaphragm. Same thing. This is normal stomach, diaphragm, and now this sphincter has gone up. This is typical of Hightest hernia. This is much better. You can see, while this the diaphragm, and now a part of stomach has entered in the chest, and this is this so-called sliding Hightest hernia. Well, option E, vascular ring, is incorrect. There are uncommon congenital anomaly in which aortic vessel encircle trachea or esophagus. They may present in infancy, but our patient is an elderly man of 51 years. It's very, very unlikely. diagnosis of vascular ring in this case, with symptom of airway obstruction, although some patients do not present even until the adulthood, but still, if 51 years is too old to have a problem of vascular ring to manifest. In the adult case, dysphagia is usually the presenting complaint, but there is no GERD, no Barium Esophagus, so this is ruled out. Well, this is normal trachea, esophagus, aorta, and now we are getting vascular ring, double aortic arch, and this is compressing the esophagus. Golden line to remember: GERD predisposed to Barrett esophagus, erosive gastric esophagitis, and stricture formation. Esophageal structure causes symmetrical circumferential narrowing of the involved esophagus with dysphagia to solid, not to liquid, and typically no weight loss because anorexia is not a feature. Other causes of esophageal structure include radiation, systemic sclerosis, and caustic ingestion. Thank you very much.